Dr. Mary Samuels. Dr. Samuels did her residency and fellowship training at the University of Colorado, where we crossed paths sort of periodically when I was there. She is now professor of medicine at OHSU in the Division of Endocrinology, and she's also the program director for the CTRC. She is going to be teaching us today about thyroid function in and near the normal range. Do variations matter? Thank you, Mary.
Thanks, Liz. Can people in the back of the room hear me all right? Okay, great. Thank you. Well, it's a pleasure to be here to talk about one of my favorite topics, and a topic that consumes a lot of time and attention in the thyroid field. And I hope by the end of the hour to convince you that it matters to other specialists and generalists as well. Let me start with some definitions so that we all know that we're talking about the same thing. So you'll all recall that this is the hypothalamic pituitary thyroid axis, and the hypothalamus secretes a number of stimulatory and inhibitory factors that travel down through the portal system and interact at the pituitary level to help control the secretion of TSH, thyroid stimulating hormone. And that goes into the general circulation and really only has one effect, and that is at the thyroid gland, to cause it to grow and to make T4, thyroxine, and T3, triiodothyronine, which are the two main thyroid hormone levels, or two main thyroid hormones. And they go to all of the other organs in the body and have all of the widespread metabolic effects that we know about. And they also feed back at both the pituitary and the hypothalamic level to help control TSH. So TSH is really at the center of this whole system, and it is, in fact, the bioassay for thyroid function, and it's the only bioassay we have. It's kind of like the thermostat for the hypothalamic pituitary thyroid axis. So what can happen is that each individual, all of us in this room and all of our patients, have a genetically determined individual set point for what thyroid hormone levels our body wants to have. And if the thyroid gland starts making either a little bit too much or a little bit too little thyroid hormone, those changes can still be in the broad population normal range, and so we won't pick that up when we measure T4 and T3 levels. We'll still think they're normal, and yet the patient could be making 20% more, 20% less than their genetic set point wants them to be at. And the pituitary gland senses this, and there's a logarithmic relationship between T4 and T3 levels and TSH. So very small changes in T4 and T3 are magnified as an early warning system by the pituitary. And so you can get these two syndromes. One of them is called subclinical hypothyroidism, and it's called subclinical because we used to think it was a laboratory artifact, and I'll try and convince you it's not. And it is a biochemical, not a clinical diagnosis. It's simply defined as the TSH is elevated and nothing else is wrong. T4, T3 levels are normal. The flip side of that is subclinical hyperthyroidism, which is defined as a low or suppressed TSH, again with T4 and T3 normal. And again, this used to be thought to be a laboratory artifact, and I'll show you that it's not. And then, so I'm going to talk about each of these entities, and then I'm going to talk about a debate that has raged within the thyroid field, because we actually don't have a whole lot of things to talk about in the thyroid field. And so we, which is lovely, actually, if any of you are trainees thinking about going into subspecialties where you can have a good lifestyle. There's been a lot of debate, all kidding aside, and a lot of clinical implications for whether variations in thyroid function in the laboratory reference range, as reported by our labs, matter. And so I'm going to talk about that too. So before I do that, what I need to do is to convince you that this matters. Because here's what most people, I believe, think about thyroidologists, although they're too nice to tell us that to our faces. And that is that we are busy counting the number of angels dancing on the head of a pin, and this doesn't really matter. So the first thing I want to do is try and convince you that it does matter. So why is this important? Well, subclinical thyroid disease, as you probably know, is extremely common, especially subclinical hypothyroidism. It occurs in up to 20% of older women, so you're going to see it in your practices. And it's almost always Hashimoto's disease because Hashimoto's disease is so common. And it does, even though we call it subclinical, it does have clinical consequences. And so in the thyroid field, we're actually trying to get away from that nomenclature subclinical, and we're starting to call it mild thyroid disease because it's really part of a continuum from normal thyroid function through mild thyroid dysfunction through overt or severe thyroid dysfunction, just like any other disease. And it does have clinical consequences, despite the fact that the T4 and the T3 are normal. The pituitary gland is smarter than we are, and it's affecting other organs as well. However, what I'll try and show you is the clinical consequences are not the ones that patients are concerned about. And so a lot of my time is spent explaining to patients that what they're concerned about is different from what I'm concerned about, and how we put that in context. The other reason it matters is that levothyroxine is the most commonly prescribed drug in the United States, and it's overprescribed. And there are clinical consequences to giving too many people levothyroxine. Sooner or later, you're going to overtreat somebody and cause problems. And then the other thing, specifically talking about the TSH normal range, is that the debate within the thyroid field has been whether or not we should narrow it at the upper end. And I'll show you the biochemical and statistical arguments for that, and then the clinical arguments for or against that. But if we do define the redefine the TSH normal range, we will instantaneously label 50 million people in the United States with mild hypothyroidism, and then they're going to attribute their symptoms to that, and then we're going to have to talk about treating them, and that's a very big deal. Millions more people who already have hypothyroidism and are on levothyroxine would need to have their doses adjusted if we readjust the normal range. So public health consequences. All right, so I've taken a case-based approach to these three entities, and I want to start with case one. This is a 55-year-old woman who presents for her yearly routine exam, and she's got mild fatigue, who doesn't, and is otherwise well, no other complaints. And on physical exam, you note that she's got a small pebbly goiter. That's that irregular, somewhat firm gland that's classic for Hashimoto's, but no other abnormalities. And so with the fatigue and the abnormal thyroid gland, you get a TSH, and it's mildly elevated. That's not actually a very high TSH. The assay range at that time was 0.5 to 5, and hers was 14. And no surprise with that mild a TSH elevation, her free T4 was 1.1. So when I present a case like this to my students, the first thing they say is, well, there's nothing wrong with her thyroid gland because her free T4 is normal. And I actually ask them, you know, raise your hand if you think there's something wrong with her thyroid gland, and nobody raises their hand. And so that turns out to be wrong, because remember I told you that small changes in free T4 are magnified and can still be in the reference range, but are picked up by the pituitary. And what I tell my students is that no healthy person wanders around with an abnormal TSH. Okay, so you do have to pay attention to these abnormal levels. You may not have to treat them, but you have to at least evaluate them. Okay, so here's a second case report, and she's a 42-year-old woman, and she was referred to me because her TSH was 7, so much more mildly elevated than the previous woman. And here's her review of systems. And I've done it for you. You don't have to do it. 83% of the items are positive. So the good news is that no blood is coming from anywhere. She's not coughing blood. There's no bloody stools. There's no blood in the urine. But basically, almost everything else is positive, including things that are not commonly associated with hypothyroidism, and including things that are actually contradictory, with, so heat and cold intolerance, constipation, and diarrhea. But unfortunately, her care provider told her that many of these symptoms were due to her mild hypothyroidism and would get better with thyroxine. And when they didn't, she came to see me because she was in distress and didn't understand why she didn't feel better. Okay, so what do these patients illustrate, and what is common in clinic? Well, usually when I'm referred a patient with these mild elevations in TSH, their priorities are feeling better because usually they had symptoms which prompted the TSH measurement in the first place, right? Fatigue, depression, you know, all that. And they want to lose weight. and they've read that thyroid hormone will help you do that. My priorities are actually different, and that is, if they've read about it, they might be worrying about long-term effects of mild hypothyroidism, but frankly, that's pretty unusual. My priorities are different. I do care about the long-term effects of mild hypothyroidism, and I'll go into that with you. But I spend most of my time explaining that the symptoms may not be related to the thyroid. I'll show you some data on that, and may not get a lot better with LT4, and I'll show you some data on that as well. And so a lot of what I do is manage expectations and clarify that just because the TSH is elevated and they have mild hypothyroidism, that doesn't explain probably most of their symptoms. So the central issue is not what the TSH level is, it's what are the known clinical effects of mild hypothyroidism, because that's what could harm the patient in the long run. Okay, so I'm going to show you some illustrative cross-sectional and then interventional studies to try and answer this question. But I don't want you to think that these are the only data out there. There are literally hundreds of articles now because we've been looking at this for about 20 years. And so I'm just going to show you some of the more recent, biggest, least biased, I think most valid data. And then I'm going to summarize all of the data for you on a single slide. So let's start with what the patient cares about. What the patient often cares about is fatigue. And so they're fatigued. They tell you they're fatigued. You get a TSH. It's mildly elevated. So the natural assumption is that the mild hypothyroidism is causing fatigue, because we know hypothyroidism does that. So here's some data that give you a different picture. And this is, like I said, not the only, but one of the largest and best cross-sectional studies out there, and it was published 5 years ago. So this is almost 6,000 community-dwelling subjects with no known thyroid disease at all. They're wandering around, they fill out a health survey, no thyroid disease, no, on thyroid medications, no. And TSH was measured in all of them. And then they weren't told their TSH results, but they were also administered a validated fatigue questionnaire and the vitality scale of a well-known health quality of life, the SF-36 survey. And the first thing I want to point out is the overall prevalence of self-reported fatigue is 36%. Now, this will not come as a surprise to you because the overall prevalence of fatigue among patients in your practice is probably 95%. But even in people who, and maybe in this room, but even in people who aren't self-selected because they came to the doctor, fatigue is rampant, okay, in our society. 36%, over a third. And what this showed was that the self-reported fatigue, either on the fatigue questionnaire or by this vitality scale, was absolutely no different between the subset of people who ended up having mildly elevated TSH levels, unbeknownst to them, and the euthyroid people. Okay? So there was no relation to mild hypothyroidism, and they also measured anti-TPO antibodies as a marker of autoimmune thyroid disease, because sometimes people say, that's the problem, it's not the TSH, it's the autoimmune process. There was no relation with that either. So, but you can see how if 36% of people are wandering around with fatigue and 20% of people, older women at least, have a elevated TSH, you can see where the correlation might accidentally be made. Okay, the other thing that they're very concerned about is weight. And this is an even bigger study published in 2009 of almost 33,000 community-dwelling subjects, again, not known to have thyroid disease, and they divided it into either women or men, and they measured their BMI. And as you can see, so this is the subclinical hypothyroid group on the left, and this is the people with, in fact, low normal TSHs on the right. So this is the most rigorous control group you can have. They didn't even allow them to have mildly elevated TSHs. And you can see that there's about a 1 kilogram per meter squared difference. In fact, in the subclinical hypothyroid, people are slightly higher. But if you do the arithmetic, it's not really a lot of weight. So when people think that they will lose 20 pounds when you treat their subclinical hypothyroidism, it's just not going to happen. Okay? The other thing, the other caveat I want to point out here is that when people have elevated weight and an elevated TSH and you see data like this, the natural assumption is that the mild hypothyroidism is driving the weight gain. And it turns out there's other information and publications out there that suggest it's the other way around. As people gain weight, their TSH tends to go up a little bit. And in fact, there are biological reasons for that to happen that I don't need to go into, that have to do with insulin and bile acids and things like that. But and I'll show you some of data from our own studies that suggests that we should not assume that the mild hypothyroidism is driving the weight gain. It might be the other way around. And that, of course, would imply that if you treat the mild hypothyroidism, you're not going to do anything much to the weight. Okay, so those were two illustrative cross-sectional epidemiologic studies, and like I said, there are a lot more out there, but they tend to show the same thing. Let me now show you a couple of interventional studies to get at the question as to whether treating this mild hypothyroidism will help, because that's really what the patients care about. Okay, and so this is an article that was just published a few months ago that got a lot of press in the New England Journal of Medicine, and it's a 12-month randomized, double-blind, placebo-controlled trial of treating mild hypothyroidism with levothyroxine. And it was an extremely well-done study, and I can almost guarantee it's not going to be done again because it turns out that studies of subclinical hypothyroidism are really, really hard to conduct, and you can't enroll enough people. And in fact, I'm incredibly impressed that they got 737 adults with mild hypothyroidism to agree to this. Some of my colleagues a number of years ago here in the United States tried to initiate a trial of subclinical hypothyroidism, and they could not get enough people to enroll. And the main reason was that as soon as people heard that they had subclinical hypothyroidism, they wanted to be treated. So this was done in Europe, and maybe there's a different kind of ethos there, but it was a very good study. And they targeted older patients. Those are the ones most likely to have adverse effects from subclinical hypothyroidism, and it's where subclinical hypothyroidism is the most common. And one of the real strengths of the study is that they first proved that in each of these cases, subclinical hypothyroidism was persistent. And that's a clinical point I want to make. If you look at a single elevated TSH in a patient, and you don't do anything about it, and you follow it for a few months, and you repeat the TSH, up to half of them normalize. Okay, so with one exception, do not jump, and I'll tell you about that later, do not jump on a single elevated TSH level because you could be committing somebody to lifelong therapy when what they had was a temporary bump in TSH. And there can be a number of reasons for that, but just to remember that mild elevations in TSH often resolve. And so one of the strengths of this study was that these are the patients where they didn't, or the subjects where they didn't resolve. You can see that the mean TSH at baseline wasn't very high, 6.4, but the range was 4.6, which was the upper limit of their assay, and up to almost 20. So kind of the range of subclinical hypothyroidism we see. And you can see here were the baseline levels in the placebo group, which is in blue, versus the levothyroxine group. And you can see, and so they followed them for 12 months, and they saw them at intervals, and in a blinded fashion, they titrated the LT4 dose to put the subject's TSH in their reference range. And you can see they succeeded. In the levothyroxine group, they dropped to a mean of 3, and in the placebo group, it stayed above 5. So the primary outcome in this study was a patient-centered outcome, and it was basically fatigue and symptoms. And they used a validated hypothyroid symptom score and a tiredness score. Here's where the money is. No matter what group they started in, and no matter what group they ended in, there was no change in any of these things. So appropriate treatment of subclinical hypothyroidism in these older subjects did not improve symptoms and fatigue. They also had a number of secondary outcomes, which I've listed here, which is what endocrinologists care about, and they also saw no change in those, but they rightly pointed out that they were underpowered for these changes, and they had only a 12-month follow-up period, so you wouldn't expect changes in things like cardiovascular events. So I'll emphasize this again, but this is the kind of stuff that endocrinologists care about because of the known end organ effects of thyroid hormone, and this is what patients care about. All right, so let me show you another interventional study, which happens to be from my laboratory. A caveat that we haven't published this yet. We're presenting it next month at the American Thyroid Association meeting, which is very fun if any of you want to go. It's in Victoria, BC. We meet in really nice places, if anyone's interested. This has not been peer-reviewed yet except in abstract form. So what we did, so my lab is really interested in cognitive and metabolic effects of mild thyroid dysfunction. And as I already mentioned, it's really hard to recruit people with stable mild thyroid dysfunction. And so we took a different tact and we developed an experimental model in the human of mild thyroid dysfunction. And we've been publishing on that for a few years now. And this is our latest study. We recruited 138 otherwise healthy subjects who had known primary hypothyroidism, mostly Hashimoto's, but a variety of causes. And they all had stable normal TSH levels on stable doses of levothyroxine. And we had them come in and do a very intensive, extensive baseline tests with sensitive measures of quality of life, mood, and cognitive function. We also did a number of measures of metabolic function. I'll talk about that later. But for now, since this is what patients really care about, I wanted to show you that data first. And after we did those baseline tests, we randomized them to one of three target TSH levels. Low normal, 0.34 to 2.5 in our assay. High normal, 2.5 to 5.6 in our assay. And then mildly elevated, 5.6 to 12. And the reason that we divided them into the high normal and low normal TSH is to get at the question of whether variations in thyroid function within the normal range have an effect. And I'll talk more about that near the end of the talk. For the purposes here, while we're talking about subclinical hypothyroidism, this is the important group. Okay. So my colleague, Catherine Schuff, adjusted the LT4 doses in a blinded fashion every 6 weeks during the 6-month study based on interim TSH levels. And then at the end of the study, we repeated all of those cognitive, mood, metabolic tests after 6 months. So first of all, in terms of the results, to show you what LT4 doses they were actually on, as expected, the low normal TSH ended up on, this is at the end of the study, on almost a full replacement dose, 1.5 mics per kilo per day. The high normal TSH a little bit lower, and then the mildly elevated TSH even lower. And the important thing is that we actually were able to achieve our target TSH levels. So mean levels 1.34 versus 3.74 versus 9.74. Okay, and here are the results of the quality of life, mood, cognitive function, and I do have weight as well on them. And basically there were no significant differences at the end of the study. And no, so there were changes in a lot of these parameters because people's weight changes over 6 months, people's mood changes over 6 months, but there were no differences at all depending on what target group you were in. And what I found very interesting is that I met with each subject at the end of the study and I asked them whether they thought their T4 doses, their thyroxine doses, were higher, lower, or the same at the end of the study compared to at the beginning of the study. And they could not accurately tell. It was random. It was like they guessed. However, I also asked them, did you prefer the dose at the end of the study or the dose at the beginning of the study, or did you not care? And overwhelmingly, something like 90% of them preferred the LT4 dose they thought was the higher dose. So if they thought the higher dose was at the end of the study, they preferred that dose. If they thought the higher dose was at the beginning of the study, they preferred that dose. And this, it confirms in kind of a quantitative way what we know in clinic, and that is that there is an intrinsic bias among people everywhere that more thyroid is better. And they read that on the internet and they talk to their friends. And this is a metabolically active hormone. The more you can give, the more metabolically active you are, the better you must feel and the less you must weigh. So people have an intrinsic bias to want more thyroid hormone and to think that they feel better on more thyroid hormone when they don't actually. So you have to keep that in mind. Okay, so here's what the patient coming to my clinic often thinks, and that is that they've just been diagnosed with mild hypothyroidism, and that is what's causing their fatigue, their depression, anxiety, and their significant weight gain. And what I've tried to show you now is that, in general, that's not true. Okay, the data just does not support that. The other thing that they're really hoping for is that if I treat their mild hypothyroidism with levothyroxine, all of these things are going to get better. And I've showed you a couple of examples, and there are others in the literature, although the intervention studies are much more sparse than the cross-sectional studies, is that that actually in general does not happen. Now, that's not to say that in an individual patient, they don't come back to you 6 months later and say, gosh, I feel better, and gosh, I've lost 10 pounds, and that's great. I do not discount that. It could be a placebo effect, but remember there's a lot of biological variability as well, and so maybe some people did respond. But on average, you cannot expect this. Okay, so here's what's really going on, and you probably know this already, is that there are 4 incredibly common things in the general population. I just showed you that over a third of people complain of fatigue, and that's in Europe. You can only imagine what it is here. You know, like we all need to go to Iceland or something, I don't know. So, and you all know how common obesity is in today's society, and depression and anxiety also rampant. And then mild hypothyroidism is also incredibly common. So there are, you know, millions of people in this overlap. And so these are true, and probably unrelated. But you can understand how patients connect the dots and think that they are related. Okay. So that is not to say that there are no clinical effects of mild or subclinical hypothyroidism. Again, 20 years of study, probably more than that now, hundreds of articles. Yes, there are actually documented objective clinical effects of mild hypothyroidism. They're just not what the patient notices. Okay, so here's what they are. I've, on this slide, summarized all those, well, hopefully most of those hundreds of articles. And I've divided it up by organ system. And this is kind of what we know. And I put some question marks in there when we're not sure. So symptoms and quality of life, we touched on this already. If any, they're mild, and they seem to be more measurable, at least, if the TSH is over 10. Lipid levels, you actually do have subtle effects on lipids, especially if you have underlying hyperlipidemia. So in subclinical hypothyroidism, the lipids can be worse, again, especially if the TSH is over 10. Lots of cardiovascular effects. Okay, lots of articles out on this now. Subclinical hypothyroidism in very, very small but measurable ways reduces LV function, exercise response, all of these other cardiovascular endpoints. And what we now finally have are large enough individual participant level meta-analyses of very large population databases. These are either cross-sectional or longitudinal, but these are observational studies that suggest that congestive heart failure and cardiovascular mortality are slightly, again, but significantly, increased, and again, much more pronounced if the TSH is greater than 10. But the patient doesn't come in saying, I'm worried about my cardiovascular mortality risk, right? So this is what I worry about. CNS, we've done studies that show that there are subtle defects in memory, but they're very difficult to, you have to use very intensive testing, and they're very small. What people were worried about, given that this is common in older women, is whether it increased dementia, and that is not true in the longitudinal studies. Lots of subtle metabolic effects, no surprise. Thyroid hormone is a major driver of basal metabolic rate, and so if you have subclinical hypothyroidism, your metabolic rate is slightly lower, and you have an increased risk of metabolic syndrome and NASH. Reproductive issues are important in our younger women who have subclinical hypothyroidism, and we do know that it increases the miscarriage rate, preterm delivery, and we worry about fetal neurocognitive development because the young fetus actually depends on maternal thyroid function until about 12 weeks for brain development. And then an age effect, I'll talk a lot more about aging when I talk about the reference range for TSH, but in fact, slight subclinical hypothyroidism may in fact be better for the elderly. So some contradictory things going on here. Notice the underlying theme here that if we see effects, a lot of times it's if the TSH is over 10 and not these mild elevations between 4 and 10 that are so common. So the American Thyroid Association has, so that you don't have to, has actually synthesized all of these data and has published guidelines for hypothyroidism and for treating mild hypothyroidism, published 5 years ago. Very comprehensive, very nice set of guidelines on all sorts of hypothyroid issues, not just subclinical hypothyroidism. And so what they recommend, and I should say what we recommend, since I'm a member of the ATA, is that patients whose serum TSH levels exceed 10 are at increased risk for heart failure and cardiovascular mortality, as I just mentioned, and should be considered for treatment with LT4. And here's what they go on to say. Treatment based on individual factors for patients with TSH levels between the upper limit of a given laboratory's reference range and 10 should be considered, and the italics are mine, particularly if patients have symptoms suggestive of hypothyroidism, and then some other things here. Well, like, who doesn't, right? So that's a loophole that you can drive a semi-truck through, right? And I've just shown you that symptoms are probably not related, and the problem is that symptoms of hypothyroidism are nonspecific. And so this is where I have to have long talks with patients and manage their expectations. Okay, so some practical take-home points. Most thyroid specialists recommend treating subclinical hypothyroidism when the TSH is persistently above 10. So the first thing you have to do is make sure it's persistent, because remember I said temporary elevations are common. And then you start with low doses of T4. You don't need full replacement doses. This is mild thyroid disease. And then you do the usual, check a TSH, adjust the dose, aim for mid-normal TSH, and very important, set reasonable expectations with patients. Okay, so after I've explained all this to the patient, and often they're already on levothyroxine and they don't feel any better, then I have to tell them, you know, this is not your thyroid. Then they ask me, okay, what is it? And that's when, as a super subspecialist, I have the luxury of saying it's often my job to tell people what they don't have and that they need to go back to their primary care physician to look at alternate diagnoses. And sometimes they do that, and sometimes they say, well, but, you know, what do you think? So I have come up with a list of alternate diagnoses that I have seen a lot of patients end up with when they go back to their PCPs. The most common one is depression and anxiety and somatization, and you all know how that presents. Fibromyalgia ends up getting diagnosed in these patients if they've got achiness and trigger points. Sleep apnea, actually not that uncommon, especially with obesity, and can lead to some of the same symptoms, and so you have to have a low threshold for that. Celiac disease, remember if these patients have true mild hypothyroidism, it's probably Hashimoto's, which is autoimmune, which puts them at increased risk for celiac. Some of them have abdominal symptoms, so it's not a bad idea to screen for that. Vitamin D deficiency, epidemic in Oregon, fatigue and muscle weakness, sometimes it's that. Hypogonadism crops up now and then, and not just in postmenopausal women, but once or twice I've diagnosed hypogonadism in a man who had a mildly elevated TSH and who also complained of hot flashes, because they get that too. So once in a while that'll show up. And then what patients come in with often is that they say, I have adrenal fatigue, because I've read about it or because I've seen the naturopath and they've diagnosed it. So just to get right out there, there's no such thing as adrenal fatigue. Your adrenal glands cannot fatigue. Okay? They can be diseased and you can get adrenal insufficiency, but they don't just wear out, even if you have tremendous stress. Okay? They have tremendous excess capacity to make cortisol. So, but remember, Hashimoto's is autoimmune. Rare adrenal insufficiency or Addison's disease, true adrenal insufficiency does exist. It's, if you're going to get it, it might be you've already got Hashimoto's, you've got a tendency towards autoimmune conditions. So once in a while, if somebody really has a lot of symptoms, terrible fatigue, orthostatic dizziness, especially if they're losing weight or something like that, I do a cortrosine stimulation test to make sure that they aren't hiding adrenal insufficiency, because that's life-threatening. And I can tell you, in the years I've been doing that, I have yet to come up with a positive test. So, but at least I can tell them that they don't have any adrenal insufficiency. And then, so that's kind of my list of other alternative diagnoses that pop up now and then. And then once in a while, you truly do find a zebra in these patients with all these symptoms. And the last one I had a few years ago, a woman with mild hypothyroidism and terrible dizziness and fatigue and orthostatic dizziness, actually. And she didn't have adrenal insufficiency, but what she ended up having after a lengthy neurologic workup was autoimmune autonomic neuropathy. And so watch for quirky, weird symptoms that show up in some patients, and follow those rather than just assuming this is the thyroid. So once in a while, you do pick up a zebra. Okay, third case report. That was subclinical hypothyroidism. Now I'm going to talk about subclinical hyperthyroidism. And this is an 86-year-old woman I've been following in clinic for a few years, originally referred to me with a persistent, undetectable TSH. No symptoms of hyperthyroidism at all, but 86-year-olds don't have symptoms of hyperthyroidism in general, even when they are hyperthyroid. And she had a really significant cardiovascular history, including what was considered very significant aortic stenosis, not surgically amenable. Okay, and there are her meds. Okay, and so I saw her. She's thin, she's elderly, and no distress, not tachycardic. There's her blood pressure, enlarged multinodular thyroid gland. There's her aortic stenosis murmur, normal DTRs, mild tremor, and here are her thyroid tests. And you can see her TSH is basically undetectable. Her free T4 and her T3 are like right in the middle of the normal range. This is subclinical hyperthyroidism. Her TSH had been suppressed for a few years. And here is her I-123 scan confirming that she's got a toxic multinodular goiter, very common in the elderly. So, patients with subclinical hyperthyroidism come to my clinic, and their priorities often are feeling better if they don't feel good, and long-term effects of mild hyperthyroidism, which they don't usually think about. The patient I just presented to you didn't even care about feeling better. She felt okay. You know, she was living at home and getting around, and she actually got referred to me by one of the residents at OHSU, because I had just given a noon conference to the residents about subclinical hyperthyroidism is bad. So the resident came up to me after the talk and presented this woman to me and said, should I worry about her? And I said, yes, I need to see her. She has aortic stenosis. So she didn't know really why she was in my clinic. So my priority is, if there are symptoms, figuring out whether they're due to the mild hyperthyroidism. And here, this is a very big deal, as I'll try and show you. What are the effects of mild hyperthyroidism? So, what are the known clinical effects? And here we're talking about cardiovascular disease. Okay, we're not going to talk about symptoms, we're not going to talk about fatigue and things like that. We're talking about cardiovascular disease. And we now have excellent, really conclusive data, most recently from well, actually not most recently, but the biggest one, because there have been publications since 2012, but the biggest one is an individual level meta-analysis of over 50,000 subjects pooled from 10 international cohorts, and they had enough power to very carefully look at total and coronary heart disease mortality, events, and atrial fibrillation. And you can see in this large group of subjects, increased risk of total and coronary heart disease mortality of 25 to 30%. Events not still increased, but not quite significant. And then AFib, big increase in risk. And you can imagine what I was thinking in this woman with critical aortic stenosis and a major increased risk of AFib, what that would do to her if she went into AFib. Okay, so again, as I did before for subclinical hypothyroidism, I've reviewed a lot of literature on what are the known clinical effects of subclinical hyperthyroidism, and I've divided it by organ system. So some people have hyperthyroid symptoms and decreased quality of life. Really, a lot don't. You do get decreased bone density and increased fractures. In fact, there's an article out just last month that proves that in a large group. And that's especially true in postmenopausal women. No surprise again, thyroid hormone increases bone resorption. And here's where the money is. There are a lot of effects on the heart. And remember, I told you AFib is a big one. Many of these cardiovascular outcomes in terms of CHF, strokes, cardiovascular and overall mortality are worse if subjects are older because they have more underlying heart disease, and if the TSH is completely suppressed versus just low but detectable. Some subtle effects in the CNS, and there is probably an increased dementia risk. There are a lot of studies out on that now, and some subtle metabolic effects. So, you know, if I was going to have subclinical thyroid disease, I would not want to have subclinical hyperthyroidism. Okay, it's a big deal. So the ATA, again, because we like to write guidelines, we're really good at it, and I was on this task force. We just published at the end of last year updated guidelines for hyperthyroidism. Again, a very nice, comprehensive, long document if you want anything you want to know about hyperthyroidism. And we had a section specifically on subclinical hyperthyroidism, reviewed all that literature I just showed you, and here are our recommendations. We divided them by age and whether you had comorbidities or whether you were asymptomatic. And this is actually a more aggressive recommendation now than the last time we updated these in 2011, and it's based on all that cardiovascular data we now have, okay? So this is, who's going to remember this, right? I don't remember this, and I wrote it. So I can probably reconstruct it if you'll give me a few minutes, but you're in a busy practice. What I would recommend, because this is much more subtle than subclinical hypothyroidism, and because the treatment options are not at all straightforward, if you have somebody with subclinical hyperthyroidism, and unless they're young and asymptomatic and you know you can just follow them, refer them to an endocrinologist. This is actually a kind of complicated evaluation and treatment decision. Okay. So what do we recommend? We recommend treating older patients with subclinical hyperthyroidism, as I just pointed out, and those with risk factors or symptoms. If they're on levothyroxine and they're just getting too much, it's easy, lower the dose. Okay. If they're not, the first thing to do is make sure the patient does not have non-thyroidal illness or NTI, because that independently, illness in general, lowers TSH levels. So if your patient is wandering around in clinic and maybe they have some chronic diseases, but you know they're doing okay, then this is not non-thyroidal illness. If they're incredibly ill and they have cancer and end-stage lung disease and things like that, then that's a consideration, and you might want to consult an endocrinologist to figure that out. And again, temporary decreases, just like temporary increases in TSH, are common. So unless it's an emergency, like someone's in AFib, that sort of thing, recheck a TSH level after 3 to 6 months and see if it's still persistently suppressed. And then what you have to do if you diagnose persistent subclinical hyperthyroidism that needs treatment is you have to figure out why they have it, and then you have to tailor treatment to the patient. And so that's where an endocrinologist comes in as well. Okay, let's move on to our fourth case. This is a 32-year-old woman, no complaints, no medications, but mentions she's considering trying to become pregnant. And her thyroid gland feels the same. It's that slightly pebbly thyroid gland, PE otherwise normal. So you get, based on that, you get a TSH, and it's right in the middle, right at the upper end of the normal range. So you remember what we said, and you wait 6 months and repeat it. And parenthetically, given that she wants to get pregnant, I might not have waited here, but you wait and you repeat it, and it's still upper normal, and her anti-TPO antibodies are positive. How many of you would treat her with levothyroxine? Okay, 2 of you. All right, let's contrast her with this case. She's 81 years old, and she comes to clinic for her annual exam. She has no complaints, blood pressure medication, vitamin D, had a mild heart attack, age 68, doing okay. Again, physical exam, slightly pebbly thyroid gland, otherwise normal. So you get a TSH in her, and it's actually mildly elevated. You go, ha-ha, could be temporary. So you repeat it, and it's still mildly elevated, and she also has anti-TPO antibodies. How many of you would treat her? Okay, nobody. All right. So this brings us to the final topic of my discussion, and that is the controversy over the normal TSH range. And first I'm going to show you the statistical and the biochemical issues that inform how you interpret normal TSH levels, and also what led us in the thyroid field, some of us, to say we need to narrow the TSH normal range. And then I'll go on to the more important topic, which is what are the clinical effects, because statistics are all very nice, but a patient is not a statistic. Okay, so the first biochemical consideration is that there's very tight intra-individual regulation of the hypothalamic pituitary thyroid axis. So the normal population, normal range of TSH is 0.5 to 4.5. That is not what people do, an individual person. And that's shown in they recruited 16 healthy people, and they had them come in every month for a year and just get a TSH level. And then they graph the TSH levels. And this is their normal range. And you can see one person turned out to be hyperthyroid. The rest of them had TSH levels that clustered around a set point, that's their genetic set point, did vary, but you can see it didn't vary all the way up and down the whole normal range. So individual TSH levels don't vary as much as the population normal range. Well, why do they vary at all? I mean, why isn't somebody's TSH always the same? And that is because TSH is secreted in pulses from the pituitary gland, both in healthy people and in people on levothyroxine. And this is just one of my older studies. This is TSH levels measured every 15 minutes over 24 hours. This is 8 a.m. to 8 a.m. the next day. And as you can see, so don't check TSH levels at night because it goes up. But even during the day, this is a healthy young man. His TSH levels range from 1 to 2.5. Okay? So it is impossible to clamp somebody's TSH. And if you have a patient, as I sometimes do, and they come in and they say, last year my TSH was 1, and now it's 2, it's doubled, my thyroid function must be cut in half, I need twice as much thyroid hormone, whatever, I have to actually draw this and say, no. There is minute-to-minute variation in TSH, not just kind of month-to-month variation. Okay? And then the final point that is what got thyroidologists all exercised about this is that the TSH reference range is skewed. Now remember, reference ranges are just like supposed to be bell-shaped curves, right? They are where 95% of healthy people fall. And this is what the actual TSH reference range basically always looks like when you plot individual people's TSHs. And it's skewed, as you can see. There's a whole lot of people there who have mild, high normal TSH levels, just like that young woman I just showed you. And so if you force the TSH reference range into a bell-shaped curve, the upper limit should actually be 2.5. And in fact, some of my more aggressive thyroid colleagues, which is kind of an oxymoron to be an aggressive thyroidologist, but they have said we need to lower the TSH upper limit of normal to 2.5. Now you can imagine what that would do to clinical practice. So the question here is, why is the TSH reference range skewed, and do we need to change it? And two competing hypotheses have been put forward by my esteemed colleagues. The first is that the upper normal range is skewed because those subjects at the upper part all have incipient thyroid disease. Okay? And in fact, it is enriched with people with anti-TPO antibodies. And so this is kind of subclinical hypothyroidism. And they shouldn't be in there. Okay? So by that hypothesis, all the people in here are skewing the TSH. And if you get rid of them, the 97.5th percentile, which defines the upper normal range, would fit a bell-shaped curve. The alternative hypothesis is that the upper normal range is skewed because normal TSH levels increase with healthy aging. And we had some past data to show that. In that case, we need age-adjusted TSH levels because at each age range, it is a bell-shaped curve. Okay. So what's true? It turns out they're both true. Okay? And so somebody finally, a few years back, took the NHANES data, which is the big population-based US survey that happens every few decades, and they took the NHANES 3 data, and they all had TSH levels, and these were people, healthy people ranging from 13 up to over 80, and they graphed what is the 97th percentile of TSH at each age range? And if you don't know the subject's antibody status, so there are probably some TPO positive people hiding in there, here's what happens as people get older, okay? It does increase with age. So the second hypothesis was right. But then if you exclude the people with anti-TPO antibodies, everything drops. So there are also people hiding in there with incipient thyroid disease. Turns out it's both true. Okay. So let's go back to our patients. Okay. And let's superimpose them on this graph. So this is the young woman who wants to get pregnant, and you can see her TSH is actually out of the normal range. That doesn't mean I would treat her, because remember I just gave you a whole big harangue about how mild hypothyroidism doesn't cause symptoms and we shouldn't treat unless it's 10, blah, blah, blah. Here's the catch. She wants to get pregnant, okay? And another clinical point I want to make is in young women who want to get pregnant, you really have to jump on their thyroid function, because remember I said fetal neurocognitive development critically dependent on maternal thyroid function. And in fact, pregnancy thyroid TSH levels are lower than non-pregnant. And so that's shown here. Here's the 97.5th percentile again. And here's our upper level of normal. Okay? And what happens if you take a woman with a TSH of 4.4 up in here and she gets pregnant, her TSH will not drop. It will actually go up because pregnancy is a stress on the thyroid gland. And she will likely become mildly hypothyroid, and that has clinical effects. It increases miscarriage rates, it interferes with neurocognitive development of the fetus, and so on. So pregnant women and women trying to get pregnant are a different ballgame. And again, American Thyroid Association guidelines, very nice guidelines on pregnancy and thyroid disease, and they have carefully considered this. And here are their very clear, easy to interpret recommendations for what to do with women either trying to get pregnant or who are pregnant, depending on their TSH levels and depending on their antibodies. And I don't remember this, and I review the data a lot. And so I either look this up or think about it for a long time. But if you've got women with these borderline TSH levels, and they want to get pregnant, don't just ignore it. Okay, you need to get those TSH levels down around 2.5 or so. And there's a whole other talk on that if you want to go into detail on that. I just threw that in so that you can think about that in your clinic. All right, let's turn to our 81-year-old woman. She actually has a normal TSH level for her age, and I would not treat her. So all of you were right. Okay, so the skewed TSH reference range. First of all, what are the public health implications if we reclassified the TSH reference range to 2.5, which is forcing it into a bell-shaped curve? The first is that you would instantaneously label 50 million people with hypothyroidism in the United States, and a third of people over the age of 70, because remember I showed that TSH actually goes up with age. And then you'd need to increase LT4 doses in millions of hypothyroid patients. Okay, so again, the important question is, what are the clinical effects? You know, who cares about the statistics and the bell-shaped curve and stuff? Okay, so again, we're going to do the same exercise. Fatigue. This is the same study I showed you in terms of subclinical hypothyroidism with the overall prevalence of fatigue in the population of 36%. And as you can see, if now you divide the TSH into quartiles within the normal range, no effects of fatigue or vitality. So no relation. Weight. Again, the same study. Here are our tertiles of TSH. And yeah, as the TSH goes up, slight increase in weight, but not very impressive, like 1.5 kilograms. And remember I told you that studies suggest that the cause and effect relationship is opposite of what you would think. So not impressive there. And here's back to my study. And remember I told you that if you look at the low normal versus the high normal TSH in my experimental model, no differences. And you remember that subjects liked the higher doses, despite the fact that it really didn't affect their weight, or they liked what they thought were the higher doses. Okay. What I didn't show you in my study were the metabolic outcomes, because we're still analyzing those and we don't have those. But I do have the baseline data to give you another caveat about thinking that you can increase somebody's levothyroxine dose, get their TSH down from high normal to low normal, and help their weight. So what we know from past studies is that high normal thyroid function does correlate with resting energy expenditure and a lot of other good things, and that's shown there. In my study, this is now free T3 levels, which is the active thyroid hormone, graphed against resting energy expenditure. And you see as the T3 levels go up, resting energy expenditure goes up, which is a good thing. However, in the same data, high normal thyroid function also correlated directly with BMI and fat mass. So as T3 levels went up, this is fat mass goes up and BMI goes up. And that's a real caveat about thinking that you can increase somebody's levothyroxine dose and help their body composition and their weight. This baseline data suggests no. Like I said, the interventional data from our study is still pending. Okay, so again, I went through the same exercise here to try and, by organ system, show you what the different effects are. This is high normal TSH, which is low normal thyroid function. Low normal TSH, which is high normal thyroid function. You see there are good and bad, there are bad things in each of these areas. We're coming to the conclusion that probably optimal thyroid function is probably a U-shaped curve in the normal range. So there's kind of a sweet spot in between there. You don't want it to be too high. You don't want your thyroid function to be too high. That's bad for the heart, bad for the bones, so on, bad for dementia. You don't want it to be too low either because of all of these things going on, okay? So you really can't win, right? You have to, it's balance, okay. And just one more very quick thing, because I know I'm running late here. I've been talking about serum levels of thyroid hormones. Well, that's not where the action is, right? The action is at the gene level inside the cell, and unless we take tissue samples and measure intracellular thyroid hormone levels, we really don't know what's going on at the cellular level. Remember I said TSH is the only bioassay we've got for thyroid function. And so there are lots of genes that affect thyroid hormone action and levels within the cell, and a couple of them are listed here. And what we now know is that we've looked for clinically significant polymorphisms in these genes, and they exist. And they actually have correlations with things that we and patients care about, psychological scores, bone mineral density, hypertension, and so on. So stay tuned, because the action probably is in the cell and not just in serum levels. But until we actually understand what's going on, we really can't use this clinically. Okay, last slide. Practical recommendations. If you have a patient with a persistent elevated TSH above 10, I would treat them with low doses of T4 to protect their heart. They may not feel better. Aim for a mid-normal TSH, but allow higher levels in older patients based on the age-adjusted normal range. Don't increase the T4 dose if the TSH is already mid-normal, because you might get some improvements, but remember the slide that showed the balance, you'll also bring on some new problems. In subclinical, that was subclinical hypothyroidism. In subclinical hyperthyroidism, you need to individualize treatment based on their age, symptoms, bone, and cardiac health, and this is really where endocrinologists can help you. And then, just as that brief clinical caveat, be more aggressive in pregnant women or women planning pregnancy, and that's a whole separate talk. Thank you very much for your attention. Be glad to answer some questions. Yes?
For many years, I resisted starting thyroid in anybody with a TSH below 10, avoiding the topic of pregnant women. Mm-hmm. And then I believe there was a large, respectable study that said a good percentage of people with TSHs between 5 and 10, in future years, the TSH went above 10, and I think they said they went to frank hypothyroidism. Right. I don't remember if they stratified for antibodies, but that made me less resistant to starting.
Right. So the question is, there are past studies out that show that if somebody has a mildly elevated TSH, but it's not yet 10, they have a relatively high rate of progression to TSH levels above 10, and in fact overt hypothyroidism, and that has led you to earlier treatment. And that in fact is true. There's in fact, TSH levels above 2.5 are associated with increased progression rates to hypothyroidism or to TSHs that are mildly elevated, and I didn't show you that data. And there are 4 or 5 studies out on that. So there's no question that something is going on, at least in some patients, some subjects, between TSHs of 2.5 and 5, and then between 5 and 10. The TPO positive patients have an even higher likelihood of progressing. So you're right, progression happens. It happens at increased rates with positive antibodies and with TSH levels above 2.5. But it doesn't happen to everybody. It's very slow. It can take decades. And what we now know is that you don't need to treat so early. You can actually wait until the TSH gets to 10, or you can wait until the woman wants to get pregnant. And you'll be treating people 10, 20 years later than you would have otherwise. So what you just quoted is absolutely true. We just now know that we don't have to intervene in that kind of prodromal stage, and we used to think that we did. Yes?
In the young woman who's desiring pregnancy, would you wait 3 months to repeat the TSH, or would you act at one?
So that's an excellent question, because normally you would wait 3 to 6 months. If she tells me that she wants to get pregnant like right away, I will repeat the TSH. You know, it's usually a few weeks, 2, 3, 4 weeks before she sees me. I will repeat the TSH then, because once in a while it'll normalize, but usually it doesn't. And if it's still elevated, I'll treat her, because low-dose thyroid hormone is completely safe in pregnancy. It's actually safe even if you accidentally overtreat her a little bit. Subclinical hyperthyroidism is safe in pregnancy. Subclinical hypothyroidism is not. So yeah, I jump on her and I say, I don't know if you're going to need this long term, but let's get you through the pregnancy, and that works just fine. Yep. Yes?
That's a great talk.
Thank you.
A lot of details. You mentioned the placebo effect on patient symptoms, and you found something that implied a placebo effect in your study.
Right.
Could you talk about the studies? Have a lot of studies randomized patients in terms of treatment and not treatment, and looked at placebo effects in terms of symptoms?
Yeah, so
what's going on?
Yeah, so it turns out, you mean specifically in the thyroid field?
Yeah.
So it turns out there aren't that many studies. There are only a very few interventional studies in subclinical hypothyroidism because it's so hard to do. And so I think there are only 3 or 4 studies. I showed you 2 of them, one of them mine that I haven't published yet. And not all of them are blinded. So there are a fair number of studies out there where they said, oh, look, your TSH is elevated, let's treat you. So that doesn't really count. And the studies that are blinded, in general, agree with this, that they don't. So there's one other big study by by Jordy, where they really didn't find any improvement. There's another interesting study by Pollack where they took people with completely normal thyroid function, but who had lots of symptoms suggestive of hypothyroidism, and they randomized them to T4 or not. And they saw, and that was placebo-controlled, and they saw absolutely no improvement in any kind of quality of life or neurocognitive findings, and they saw increased anxiety levels. So it was actually bad for them. So when you look at the very few studies out there that are truly blinded, the data is very unimpressive. Yes?
Thank you for your helpful talk. 2 questions. What does stress do to TSH? And second was, I forgot.
It's because you're under stress. Okay, so the regular kind of stress that we walk around with and that our patients have, psychological stress, sometimes some medical stress, really doesn't affect TSH very much at all. Severe stress, and by that I usually mean medical stress, can lower TSH levels. And a lot of that is thought to be cortisol mediated, because it turns out that if you've got adrenal insufficiency and you're not on cortisol, your TSH is a little higher. And if you actually replace hydrocortisone in a physiologic fashion, the TSH comes down. So TSH is physiologically mediated by cortisol. And if you have very high cortisol levels for a very long time, your TSH can be low, but you really have to be under tremendous stress. So the kind of stresses we have and our patients, our ambulatory patients have, don't count for that. But if you have somebody who's really ill and they're walking around chronically ill with lots of severe comorbidities, they may have a lowish TSH. It's almost never undetectable. In order to suppress the TSH enough from stress and illness so that it's undetectable, you basically have to be in the ICU on a ventilator. So you might see a TSH of 0.3, you won't see a TSH of 0. The other caveat there is that once you put somebody on prednisone or any kind of glucocorticoid, that directly suppresses TSH. So those patients will have a low TSH.
BMI increase
So it is not known how obesity leads to high normal or mild elevations in TSH. There are some postulated biochemical mechanisms in animals, but it's really not known. Not known. Sorry?
Does weight loss improve the normalizing TSH?
It can, yes. It's supposed to stop.
Yeah.
Oh, it's okay. I actually practiced this yesterday and it was only 50 minutes long.